Hello, and welcome to our webinar, Science, Stigma, and Statutes, Defending HIV-Related Charges in Indiana. I'm Dr. Carrie Foote, and I'm a professor of sociology at IU Indianapolis. I'm also a co-author of the Williams Institute reports that I'm going to present to you today on the enforcement of Indiana's HIV criminalization laws. I also chair the HIV Modernization Movement Indiana, which is a grassroots network led by people living with HIV, seeking to modernize Indiana's HIV criminal and related public health laws. I've also been living with HIV since 1988. I'm joined today by my colleague Todd Fuqua. Todd is a community archivist and health educator. They serve as the network building lead for HMM Indiana and are also a person living with HIV since 2012. Our objectives for today are to present an overview of HIV criminalization and then to describe some of Indiana's HIV criminal law enforcement patterns. We will also apply current HIV science to assess relevant harm or risk of HIV transmission in these cases, as well as to recognize the impact of HIV stigma in these cases and apply defense strategies. And finally, we'll identify ethical responsibilities of representing people living with HIV and summarize current reform efforts in Indiana. Okay, so let's get started. What is HIV criminalization? It's simply the use of criminal laws to penalize people living with HIV for non-disclosure, potential exposure, or transmission of the virus, often regardless of actual risk or intent to transmit HIV. This can occur under HIV-specific laws that apply only to people living with HIV or under general criminal laws where charges are enhanced because of a person's health condition. Many cases in Indiana involve acts that pose zero risk of HIV transmission, including spitting or sex using proven prevention methods. Importantly, about 9 states, including right here in Indiana, also criminalize people living with viral hepatitis. This is a map of which states have these laws across the U.S. About 30 states have some variation of laws that criminalize people living with HIV. Many of these states have been working on reforming these laws, including here in Indiana. If you want to look at the history of the timeline of reform in the different states that have worked on reform, you can scan the QR code and it'll take you to a website that shows a detailed history of reform efforts. These are the laws that exist in Indiana that criminalize people living with HIV. They fall into 3 types. In the first bullet, we have the battery and malicious mischief by bodily fluid waste codes when it contains either HIV, tuberculosis, or viral hepatitis. They start out as general criminal laws for anyone in the state of Indiana, but if you know you are living with one of those diseases, there's felony penalty enhancement solely because of the health condition. The second is our duty to inform laws. These involve health and criminal code and require a person living with HIV or viral hepatitis B to inform their sexual or needle-sharing partners of their status prior to a high-risk activity that, according to the CDC, has a significant risk of transmitting HIV or viral hepatitis. If they don't, they can face felony penalties. And then we have donation codes where it's a crime to attempt to donate, sell, or transfer semen for artificial insemination or blood and plasma when knowingly HIV positive, and like the ones before, they also result in felony penalties. Importantly, as you also see, these laws were enacted decades ago, as early as 1988, as recent as 2002, which is over 20 years ago. The duty to inform law was modernized in 2020 to make some changes to reflect advances in HIV science. So what's wrong with these HIV criminal laws? As I just mentioned with the dates, these laws were written before modern advances in HIV treatment and prevention science and have mostly not been updated to reflect these changes. We know today that HIV is not easily transmitted, and with treatment, the transmission risk can be negligible to none. HIV is also a very manageable chronic condition. It is no longer a death sentence like it was back in the 80s when we didn't have treatments. With today's treatment, a person diagnosed in their 20s can expect to enjoy a normal life expectancy. This is a statement from the National Association of Criminal Defense Lawyers, published in 2016, and some of the key takeaways that they identified as to what's wrong with HIV criminal laws. First, they rely on knowledge of HIV status as a key element of the crime, rather than criminal intent of a person or actual harm, such as did transmission of HIV occur. Instead, it's the knowledge of HIV status that is punished. And then penalties are often extremely disproportionate to actual harm and can reinforce stigma as compared to crimes involving actual harm against a person. These laws also mostly ignore scientific evidence and criminalize conduct posing little or no risk. So the key takeaway here of what's wrong with these HIV criminal laws is that they reflect outdated science and weaken mens rea standards, resulting in over-criminalization and unjust outcomes. Let's just pause here for a moment and look at what actually does transmit HIV and what doesn't transmit HIV. It's really important to know that not all exposure to HIV will result in risk of transmission. Let's be clear here, HIV is not transmitted through contact with saliva, urine, feces, or fluid that can transmit HIV, such as blood or semen when it's outside the body, for example, through acts like throwing or spitting. There is also extremely low risk of transmitting HIV through biting that involves broken skin and blood from someone with HIV. We also know that HIV is predominantly transmitted through sexual intercourse and sharing syringes with somebody living with HIV. However, we have incredible prevention tools to prevent HIV transmission today. So today, we now know that a person with HIV, when durably undetectable, cannot transmit the HIV virus to others sexually. So essentially what that means is that someone like me who takes their HIV treatment and is undetectable, meaning they cannot find HIV in my blood, I can have condomless sex and it's impossible for me to transmit HIV to my sex partner. We call this U equals U, or undetectable equals untransmittable. HIV transmission can also be prevented with HIV testing, medication known as PrEP, pre-exposure prophylaxis that the person who doesn't have HIV can take to prevent HIV, and safe syringe access, as well as condom use. And then I always like to show this chart from the CDC that shows the per act risk of acquiring HIV in the context of no prevention measures. So as you can see, when it comes to sexual behaviors, such as those that are criminalized under our duty to inform law, that even the riskiest sexual act is extremely low per 10,000 exposures. And then, of course, with prevention efforts, we can pretty much eliminate HIV transmission. Okay, let's look at some of the research now. People, especially lawmakers, were wondering, well, what's happening out there? Are these laws even being used? And if used, how so? So I worked very closely with my colleagues at the Williams Law Institute at UCLA to analyze court case records as well as probable cause affidavits associated with cases involving one or more of Indiana's HIV criminal laws. You can access the full reports by scanning the QR codes, and we also have a link at the end of our presentation to the reports. Here I'm just going to give a quick overview of some of the key findings. For our transmission risk report, we analyzed the statute language rather than actual cases. We asked, based on what the language says, are we criminalizing conduct that can even transmit HIV? And what we found was that none of these laws require actual transmission, so a direct bodily harm to prosecute somebody, nor do they require the intent to transmit HIV. So they're kind of missing some of the key components of what you might normally think of for crimes against a person involving felony penalties. What we found is that these laws don't require harm or intent to transmit HIV. We also found that there's effectively no risk of HIV transmission in the conduct covered by the battery by bodily fluid and waste laws, as well as the malicious mischief bodily fluid waste laws, yet penalties are enhanced solely based on a person's HIV status. Finally, in Indiana, HIV status under the duty to inform law does reflect some advances in HIV science that resulted from the bill that in 2020 House Enrolled Act 1182. By limiting criminalization to higher risk activities such as certain sexual contact and needle sharing identified by the CDC as posing significant transmission risk. Looking at the donation laws and what's happening on the ground, we identified 18 cases across 4 counties between 2001 and 2023. The last case that we could find that was prosecuted was filed in 2018. None of those involved whole blood donations or semen donations. All of them were for attempts to donate plasma. There were no allegations of actual transmission or intent to transmit HIV. And then just some background around plasma safety. It's important to know that across the United States, including here in Indiana, there's been no reported cases of HIV transmission from plasma donation in the U.S. in 40 years. And this is due to FDA blood supply safety measures that were implemented in the late 80s. So essentially, there's no risk of contracting HIV from the blood or plasma supply today from somebody who knows their HIV status. The same is for semen too. There are FDA safety measures in place today. Looking at the bodily fluid waste exposure laws, we identified 51 cases across 17 counties between 2012 and 2023. Nearly all were under the battery by bodily fluid law. 49% included public safety official enhancements. There were 0 cases involving acts capable of HIV transmission. 82% involved saliva, which cannot transmit HIV, primarily spitting. 3% involved urine, 15% involved blood on clothing or intact skin, and there were 0 cases of alleged HIV transmission. We only have preliminary data on the duty to inform law. At this time, we identified 61 cases across 22 counties between 1998 and 2024. Most of these involved men in sexual relationships with women. We found evidence of the defendant being on HIV treatment or engaged in HIV care in 39% of these cases. Do you remember when I talked about risk of HIV transmission and how treatment reduces transmission risk? Being on treatment makes sexual behavior a low-risk behavior and zero-risk behavior if they are undetectable. In 36% of the cases, the defendant waived their Miranda rights and made a statement to law enforcement. No cases involved individuals with hepatitis B or non-disclosure to needle-sharing partners. Looking at current enforcement data in the previous 5 years, we find only that some of the laws are being used. This is helping us guide reform efforts, something we call evidence-based reform. In addition, the context from the probable cause affidavits is helping us decide how best to modernize these laws. So in effect, we can update the laws to directly reflect what's empirically happening in these cases. So what we found is that the most widely used law was the battery by bodily fluid law, followed by the failure to inform law, and then the malicious mischief law. There were 0 cases with the donation laws. So we are focusing our reform efforts on the enhancement laws to repeal the enhancements for HIV, or at a minimum require substantial risk of transmission as a requirement to prosecute under that crime. And then under the duty to inform law, we are exploring ways to modernize that law to be an intentional disease transmission law. So a law that would require actual intent to transmit HIV, possibility of transmission, and actual transmission. In conclusion, on the donation and battery report, we found the donation laws are no longer enforced. The battery law is misaligned with science and fair punishments. There is no transmission risk under these laws, yet felony charges are applied, so there's excessive penalties compared to actual harm. So we're finding disproportionate penalties when compared to other laws that punish alleged bodily harm. Penalty levels, when we compare to other crimes in Indiana where actual harms occur, is that the penalty level in these laws where there is no harm or no possibility of harm are equal to crimes and punishments involving moderately bodily injury or strangulation. And in cases involving public safety officials, penalties align with offenses that can result in death. Yet keep in mind, no harm is occurring and no harm is actually possible under these particular codes. The key takeaway here of these 2 reports is that the HIV enhancements punish people based on a medical condition rather than any actual harm caused, and breaks from penalty structures that scale with injury severity. Now I'm going to turn it over to my colleague Todd, who's going to summarize the disclosure report findings.
Before I share the research conclusions about the duty to inform law, I want to break down that law in a little more detail, because for conviction to actually occur, the state must establish three elements. First, the person knew they had HIV at the time of the alleged offense. Second, they failed to inform their sex or needle-sharing partner of their HIV status prior to the act. Third, they engaged in a CDC-supported high-risk activity. The last one is what appears to be missing in a lot of these cases in the charging documents. When we looked at the probable cause affidavits, they rarely went beyond simple allegations that sexual contact occurred and proof of a defendant's HIV positive status. They really didn't talk about the details of their sexual contact or whether any prevention measures were used. We've developed a great training video on this topic alone about the duty to inform law that goes into much more detail about this law. So if you're interested, you can watch that video. It's on our YouTube channel for more information, and it's also in this course if you're watching this video from a course selection on our YouTube channel. So the conclusions of the duty to inform findings is that some people are being charged for low to no risk acts, even though the law only applies to high-risk sexual acts. There is also a lack of legal literacy, meaning people living with HIV who are durably virally suppressed may admit to doing wrong when questioned, when in fact they were not required to disclose under the law. Stigma may be a major barrier to disclosure for many who get charged. We also find a disproportionate enforcement of that particular law. People with viral hepatitis B, which far outnumber people living with HIV in Indiana, are also required to disclose their status under the statute. Yet we couldn't find one case of anyone living with viral hepatitis B being charged under that law, which could reflect the greater stigma associated with living with HIV. So the key takeaway of this report is that the revisions made in 2020 under House Enrolled Act 1182 to align with current science are not well understood by law enforcement, defendants, prosecutors, or defense lawyers. Before we talk about defense strategies, let me touch on our role in this conversation. We are not lawyers. We're not here to tell you how to litigate your cases. What we can offer is this. We understand the current HIV science. We understand how that science intersects with Indiana's laws. And we can see patterns in how these cases are being charged. We have also had conversations with lawyers who are closer to these types of cases and have gleaned some possible strategies. With all that information, the goal is simple: to help you test the state's assumptions, to get clear on what the statute actually requires, and to push for precision where the law demands it. That's where we see the biggest gaps for now. So what does the science mean for your defense? This is where science shapes what actually counts as harm. As we understand the law, the relevant harm only matters if it connects to three things in these cases: a defined transmission risk that is recognized by the CDC or other credible scientific authorities and is tied to what actually happened. If you can't check those boxes, you don't have relevant harm. So start there. What was the conduct? Is there a recognized transmission pathway? Was there a substantial risk of transmission? If not, the harm the state is pointing to isn't legally relevant. And that brings us to what doesn't count. Emotional distress by itself is not enough. Fear is not enough. Stigma and assumptions about HIV are not enough. In our research, the biggest gaps we're seeing in the PCAs for the duty to inform law are outdated beliefs about transmission. These need to be challenged in court. And even though the battery code doesn't explicitly include risk factors, we still encourage you to raise the lack of risk because the laws are outdated and the science has changed. How does stigma show up? It actively shapes how cases are charged, described, and decided. You will see stigma shows up immediately in the record. Stigmatizing language appears in police narratives and probable cause affidavits. The caution image in this slide is from a PCA in 2024, where the defendant was labeled as contagious. Now, is that really warranted? What is critical is we see overstated or inaccurate ideas on HIV transmission risk. Charges are often based on the false premise that any sexual conduct is high risk. Any bodily fluid exposure is assumed to be high risk. Spit doesn't transmit HIV, and yet we see felony enhancements in 82% of the battery cases. We also see alleged victims receiving testing or PEP when there was no risk of transmission. Think of PEP as the morning after pill for HIV. It reduces the risk of transmission after the fact. So for example, I'm living with HIV, and if I were to spit on you, you don't need to take PEP. Spit cannot transmit HIV. These actions reinforce the narrative that harm occurred, even when it didn't. Lastly, we see stigma showing up around non-disclosure and how it's interpreted. Someone may not disclose their status out of stigma, fear of rejection, or fear of violence, but that non-disclosure is often reframed as a malicious intent. That is problematic. The problem in these scenarios is that assumptions start replacing evidence. HIV becomes synonymous with harm. Contact becomes synonymous with risk. And non-disclosure becomes synonymous with intent. None of those are legally valid shortcuts, but they show up in case narratives all the time. If nothing is done to challenge these assumptions, stigma becomes part of the evidence. And that language is not neutral, it's prejudicial. What does it look like to address stigma in these cases? It's important to note that almost no cases so far have gone to trial. They are plea bargained out. So we lack successful defense examples in Indiana. But here are some things to consider. At a basic level, keep the focus on evidence instead of assumptions. First, with the duty to inform cases, the conversation needs to focus on risk. In these cases, what we see is exposure gets used loosely, but the statute ties to define transmission risk. So the question becomes, what evidence is there of an actual CDC-supported significant risk? With these cases, things like viral suppression or U equals U, route of transmission, and risk reduction measures come into play. If the state cannot prove their CDC-supported significant risk, their cases fall apart. Another situation to consider is where the alleged conduct cannot transmit HIV at all, like spitting on someone in the battery cases. In these situations, the case can start to rest more on fear or misunderstanding than on medical reality. Use experts to ground the analysis in current science and build arguments from there. For example, we've heard it suggested that one could argue for dismissal based on scientific impossibility. Third, on the HIV enhancements involving battery and malicious mischief laws, we'd suggest focusing on the underlying offense and consider challenging the enhancement. These enhancements turn on HIV status, not on transmission, not on risk, and not on harm. As you know, that raises constitutional questions. Under Article 1, Section 23 of the Indiana Constitution, we're now treating two groups differently for the same conduct. The question is whether there's a real difference that justifies that. If the conduct cannot transmit HIV, that distinction gets harder to support. There's also a proportionality angle. Article 1, Section 16. Punishment has to match the offense. So we might ask, what added harm justifies the enhancement? If there's no transmission risk, that's a harder case to make. We're not telling you how to litigate it, but it's another place to look, including motions to strike or dismiss the enhancement. The other thing to consider in HIV-related cases is the process itself can carry consequences beyond the charge, which add to HIV stigma. HIV status is highly sensitive personal health information, and once it's in the record, it's hard to contain. You'll see it show up in places like charging documents, probable cause affidavits, open court, and sometimes media coverage. And once it's there, it can follow the client outside the case. Even where charges are resolved or dismissed, there can be collateral impacts, employment, housing, relationship. So there's a tension here. You're addressing the charge, but also dealing with how that information moves through the system. And I always like to point out these headlines on the right-hand side, particularly HIV positive man gets jail for spitting on cop. When that gets published, what does it tell the public? It tells them that you must be able to get HIV by spitting on somebody. And we know that that's not true. And that's why media coverage and stigma can be so dangerous in these cases. We can also tackle stigma by considering the ethical aspects of addressing how misinformation is handled, as well as managing confidentiality. First, it's important to correct bad science and challenge misinformation. HIV is a relatively difficult virus to transmit to others. Today, we fully understand those transmission routes and their relative risk. As we've shown, many alleged acts carry no risk. Second, maintaining confidentiality is critical in these cases. HIV status can enter the case in ways that go beyond what's legally necessary. And once it's introduced, it's hard to pull back. Part of the work early on is just noticing where and how HIV status is documented. And then thinking about ways to keep that information confidential and not available to the public. There are tools you already know, such as obtaining your client's consent to disclose their status, limiting disclosures, filing motions to limit stigmatizing language, or to redact or seal all or part of the record that mentions HIV. You can also consider protective orders and in-chamber hearings to limit what's revealed in open court. It's important to remember that these laws involve a person's HIV status that is often revealed publicly. This can create additional harm for your client in the community because of HIV stigma. As we get ready to close, let me give you a quick context on where the law stands today. This slide shows a history of HIV modernization bills, including ones that have passed into law. There have been some updates over the past few years. The duty to inform law now requires CDC-supported significant risk to prosecute. We've also removed stigmatizing language from all of the statutes. More recent efforts have focused on repealing the felony enhancement tied to HIV status. We've passed language in the House. Our focus now is on education and advocacy with key players in the Senate. This year, there was success with Senate Enrolled Act 180 in removing a duplicative, unused portion from the health code around semen donation. That law has never been used, but it cleans up the code and keeps criminal penalties in criminal code where it belongs. The bigger point here is the law is evolving, but not quickly. And in practice, we know it's often not applied in line with current science. So right now, a lot of that gap gets worked out in individual cases. So you're on the front line with these efforts. We hope this workshop gives you some new information to help defend these cases in the future. In that frontline role, we offered up some legal resources to support you. We can offer peer support to your clients. We also have a series of HIV criminal law resources and fact sheets on our website. Go to the Get Help page or scan this QR code. We can also connect you to attorneys who have background in HIV criminal law and can share other resources and legal insights to consider in your cases. We have also partnered with the Indiana Public Defenders Council to develop defense guides for our laws that can be used by defense attorneys. These guides connect the laws to current HIV science and provide defense strategies for cases as well as sample motions. We published a guide on the duty to inform law, as well as one on the battery and malicious mischief laws. These can be found on our Get Help page or using the QR codes below. They're also available from the Public Defender Counsel's Motions database. Here are some resources for legal support, scientific reference, and policy guidance. The Center for HIV Law and Policy is a great source of information. We've also included materials that help align practice with evidence-based understanding of HIV transmission. The last item here will take you to all of the research reports from UCLA and IU on the enforcement of our HIV laws in Indiana. I know we've covered a lot of ground today. Our final guidance is to protect HIV confidentiality early, to challenge misinformation about HIV science every time, to limit HIV stigma in the record, and to force the state to prove risk of HIV transmission. Thank you for taking the time to learn about our research and work. If you support efforts to modernize Indiana's HIV criminal laws, we encourage you to sign on in support of reform and join our newsletter listserv. Please feel free to contact us with questions or collaboration inquiries.